Okay, so we're going to talk about stimulants, and these treatments have been around since the 1960s. And I want to mention that there were 20 lawsuits brought against a company that made Ritalin back, I think it was in the 1970s or early 80s. Turns out that they were sponsored, the attorneys were paid for by the Church of Scientology. All 20 lawsuits, and there's been this ongoing battle between the American Psychiatric Association and the Church of Scientology, and so it's just, commentary on some of the, media kind of issues that get kicked up because of medication treatment. But anyway, in terms of stimulants, lots and lots of studies with kids, and have been around for a long time. Safest psychiatric medication. You know what? I don't think I've got this slide in here. Hang on just one moment.
Did you say Ritalin also?
I beg your pardon?
Did you say Ritalin? For this year? You said Ritalin.
Well, stimulants.
Okay.
I mean, we're looking at there's a whole bunch of different stimulants. There's a slide that I didn't include. Let me just mention this, okay? And that is, there have been 25 deaths of children, Canada and the United States, in the last 10 years. These kids are taking stimulants, and it caused concern. And for a while, the Canadian version of FDA banned the use of Adderall, but then they allowed that now to be used again. And it turns out that the base rate of sudden death in children on kids taking stimulants is really no different than the base rate in the general population. And every one of these cases, on autopsy, they found that the kids had evidence of pre-existing, actually pretty severe cardiac disease that had been undiagnosed before starting treatment. And so here's what you need to do to just absolutely make sure that it's not going to put kids at risk, because stimulants increase heart rate a little bit, increases blood rate a little bit. So for most kids, it's no big deal. But if you have a family history of cardiac disease, also a family history of sudden infant death syndrome, okay, then those are risk factors, okay? Or if you have any of the following symptoms, okay? One is called syncope, which is unexplained fainting, okay? Where people just lose consciousness and faint. If you have rapid heart rate, if there's been a history of fetal alcohol or other substance abuse exposure, then these are risk factors that suggest that you need to do cardiac screening before prescribing a stimulant. And it's as simple as getting an EKG. And if that comes back normal, then you can prescribe the stimulants, and there's really no problem at all. Okay. One reason I want to mention that is this is, again, one of those things where if parents get on the internet, they may see, ooh, look, a sudden death associated with the use of Adderall or Ritalin or what have you, and that's the current state of affairs. So FDA, their position on it is there's no reason to think that these are unsafe medications. In fact, again, they're the safest medicine in all of psychiatry. Yeah?
What did you call it when the person faints easily? What's the term?
It's called syncope. Okay. Mechanism of action. All of the stimulants are dopamine reuptake inhibitors. Okay. In addition, though, amphetamine, it's a dopamine reuptake inhibitor, but amphetamine also increases the rate of the release of dopamine. Okay. And so, just like, with the serotonin reuptake inhibitors and that kind of stuff, fast action, usually you take a stimulant and within 45 minutes to an hour, it's up in the brain, it's blocking dopamine receptors. So guess what? It just allows for the accumulation of more dopamine in the synapse rapidly, and as long as that is sustained, as long as the drug is active, then it normalizes brain functioning in the frontal lobes. Okay. Yeah.
So that's 45 minutes to an hour
Yes.
until there's more dopamine at the synapse level?
Right. Right, and that's exactly when you see the onset of behavioral changes. And if you ever work with kids with ADHD, but it's dramatic. I mean, it's huge. Okay, so there are 3 classes of stimulants, and methylphenidate is Ritalin. But then there are a lot of Ritalin clones. You can look in your quick reference to psychiatric medications, and you'll see drugs like Concerta, Metadate, Focalin, and so forth. They're all derived from the same molecule, methylphenidate. They differ in terms of whether they're immediate release or if they are sustained release and that kind of stuff. But the compound itself is the same thing. Dextroamphetamine is dexedrine, okay, and it's been around for a long time. And amphetamine is Adderall, okay. Adderall has actually 2 variants of amphetamine. Actually, this is just hard to believe, but FDA has approved the use of methamphetamine for the treatment of ADHD. Nobody in their right mind would prescribe it, you know, because even though it works for treating ADHD, you know what's going to happen? Their parents are going to take it, or the kids are going to sell it, you know, or something like that. So, anyway, Vyvanse is a prodrug, okay, and if you remember, a prodrug is a drug that doesn't become active until it is metabolized in the liver. And so this drug is a stimulant, but you can't abuse it by smoking it or snorting it or injecting it into a vein, okay? And the drug company came out with this thinking that it would result in less abuse potential for that reason. It has to be swallowed, go through the liver, and then it is metabolized into the drug that works. It's a prodrug. Okay. Whoops. Dang it. Strattera is methylphenidate, which is Ritalin, but it's in a transdermal patch, like the nicotine patch. You put it on your skin, and you have to replace it every day. Now, I don't really know that this is going anywhere because of this. It requires 3 hours before it reaches therapeutic blood levels, and usually kids wake up and you know, they're wild and they're making funny noises and bugging everybody until the Ritalin or Adderall gets in their brain 45 minutes later, and then they're okay till it wears off. What you'd have to do here is you'd have to give it to the kid. You have to sneak into their bedroom, like at, you know, 5 in the morning or something like that, you know, and stick a patch on. Some parents probably do that. I mean, sometimes, especially with severe ADHD, that first hour in the morning is just, it's really, you know, it's bad news. But anyway, it may just be a marketing kind of thing, trying to, you know, make more money.
So what would be the benefit of that?
I don't know what the benefit is at all.
Oh, okay.
Okay. Benefit is the drug company makes more money.
Yeah.
Okay, now, if you look at cross studies, these are impressive outcomes. Okay, if you just treat kids, this assumes that they really have ADHD. Okay, with appropriate doses, which are high doses, okay, of stimulants, 72% have good to excellent responses. Systematic trials, it goes up to 92%, and I'll talk about that in just a minute. When the drug is in their body at adequate blood levels, somewhere between 1/2 and 2/3, they look completely normal in terms of their cognitive functioning, impulse control, and so on and so forth. And look at the effect size. Again, one of the highest that you find in psychiatry. Now, however, if you give it to kids that are really young, and you better believe it, some people are getting treatment for kids that are 3 and 4 and 5 years old, the response rate is much lower, but you see it start to increase, and by about the age of 6 or 7, now you're up to these rates here. And the likelihood is this is because the dopamine system is still coming online maturationally, so it's not it's not able to have an impact because the system itself isn't really fully operational yet, but good outcomes. Now, this is what you see in a number of different kinds of studies where they look at metabolic brain functioning. Over here on the left-hand side, it looks like there's a hole in the brain in the left frontal lobe and also other areas in the left hemisphere, but it's not a hole in the brain. This is just a particular part of the brain where the metabolic activity is way below normal, okay? And 1 hour after taking a stimulant, it's become completely normalized. So for all practical purposes, most of these kids, once the drug is really on board, they can function just fine. The downside is the drug wears off, and you can't take it late in the afternoon or evening because it'll keep you awake. And so that's where there were problems. But when it's there during the daytime, then the results are very impressive. Okay, now I thought I had another slide in here. Maybe I didn't, but let me talk about this for just a minute. What's been found is that gosh, why didn't I put that slide in? Well, I'll just tell you about this. Okay, what's been found is that 38% of kids who are given a stimulant, if you do trials on the different classes of drugs, one of those drugs will stand out as being the best, okay? The rest of kids, which is the majority, about 2/3 of kids, they're equally effective. Now this is not uncommon in psychiatry to say, well, yeah, but they all supposedly work the same way, so why aren't they equivalent? And the answer to that question is, who knows? Okay, but here's the practical reality of this. Okay, what happens is you get a kid, and maybe they've been a huge behavioral problem for years, and so finally the parents take them in, and the pediatrician gives them, and let's just say Ritalin. It could be any of the drugs or Adderall, but let's say they give them Ritalin, and they go home and they give them the medication, and within an hour it's like, whoa, why didn't we do this 2 years ago? And so they stay on the drug. And it works and continues to work, and parents and teachers and everybody are pleased with that. But what you don't know is, could this kid be in that group, third of kids, that actually might do better on Adderall? Because the success of this is so good, then you just stay with it. I mean, why try to fix something that's not broken? However, if you want to get up to from 72 to that 92% effectiveness rate, then the way to go is to take a month and with a trial on one class of medicine, like Ritalin, methylphenidate, a month on Adderall, and a month on Dexedrine. 2/3 of these kids is going to be equivalent, no big differences, but 1/3 of them, one of them is going to actually, hey, this really is better. Now, if you do that and you multiply that times the years, with a child's life, grade school, junior high, and beyond, the effect could be significant. So the people that are experts are saying two things about treatment. One is don't pussyfoot around. Use good aggressive dosing. And you don't want to get to the point where you get side effects, but you try to really push it, get the maximum benefit, and do systematic trials, okay? And a lot of kids are going to find out one drug actually is superior to the other two classes of drugs. Now, what else can you do? Well, the biggest problem really is dealing with evening hours, okay? Because it's not just about getting homework done, but it's because absolute chaos occurs in many of these families at night because the kid is, really out of control. And somebody, I don't remember, the conference said, hey, you mix siblings and ADHD and it's explosive. And so it really makes a big difference. So it would be nice to be able to have a drug you could use that's going to provide a benefit in the evening, but again, you can't take stimulants because they'll keep you awake at night. So this is where antidepressants can be effective. The two antidepressants are Wellbutrin and Strattera, and we'll talk about each one of those. Also, just as an adjunct or augmentation, you can add alpha-2 agonist, which would be clonidine or guanfacine. And actually, these drugs can cause sedation. So You can use it, for instance, some people have some side effects of having trouble going to sleep. They don't quite get all the stimulant out of their system, so they have some trouble with initial insomnia. Give them clonidine and make them tired to go to sleep. The clonidine itself actually reduces especially impulsivity and aggression. So it's not rare that you'll see that used in combination with stimulants.
What was the second one? Clonidine
And guanfacine.
and guanfacine?
Yeah. Okay, and then this is very interesting and kind of counterintuitive. This comes out of the Texas Medication Algorithm Project, and their new recommendations are if you have ADHD and comorbid anxiety, and 25% of kids that have ADHD qualify for an anxiety disorder also. Now this is not true with OCD, okay, but usually it's like generalized anxiety, is instead of treating the anxiety with a separate drug, which might usually be an SSRI, is go ahead and treat them with a stimulant, and in about 6 weeks, half of these kids that have anxiety disorder, anxiety goes away. Now, why I say it's counterintuitive is people have said, yeah, but they're already anxious, give them something that revs them up a little bit, they may get more anxious. But actually, probably what's happening here, this is, it's just an empirical finding, a lot of the anxiety goes away, but almost certainly it's because, why are they anxious? Because their whole life, they're failing. They're failing at making friends, they're getting rejected, there's family conflict, they're doing poor academically. This stuff starts to improve, and they calm down. So rather than loading this kid up with additional drugs, give it a trial and see if that one drug alone is going to make a difference. Yeah.
I have a question, and
Yeah.
I apologize if you said this already, but are these treatment recommendations specific to kids and adolescents? Is there different treatment recommendations for adults with ADHD, or is it the same?
Well, no, it's a good question. And the same treatments work for kids as well as adults, okay? And I think there's a tendency with adults to start off with Strattera or Wellbutrin to see if that does the trick. And if it doesn't, then you can go to stimulants. But basically, it's the same for kids, teenagers, and adults. All right. Okay, a couple of specifics here. Start meds on the weekend so parents won't see only rebound. Here's what happens a lot of times is you go to the pediatrician and they'll say, okay, now here it is, Friday afternoon, start Jimmy, on this Monday morning, and then let me know how it turns out, okay? So what happens is they put the kid on medication, send him to school, and the teacher goes, whoa, thank God they finally got this kid on medicine, But then they'll come home, and by the time they come home, the medicine's worn off. But also, often in the early stages of treatment, you will actually get rebound. So not only has the kid lost the effect that they were showing at school, but actually some of their out-of-control behavior may be even somewhat more than usual. And so parents are going to go, well, God, this doesn't work, let's forget that. And then they stop doing it. So the recommendation is you try it on a Saturday. And that way the parents can say, whoa, this stuff really works, okay? Because with kids, it all so much of it rests on whether or not parents are on board about using the medication or not. Start with short-acting stimulants. The only reason here is to find out if there's an allergic reaction or something like that, but then it's better to go to longer acting. They used to only have short-acting or immediate release drugs, so kids would have to go take a dose, midday or at lunchtime at school. They have to go to the nurse's office or something, and that was a pain in the neck, but also oftentimes embarrassing for these kids. And why are you going to see a nurse every day and that kind of stuff? So most of the drugs now, you can take it once a day in the morning. It'll get you through. The question of tolerance. Okay, now the current consensus about this is that people don't develop tolerance for this. What you see clinically is maybe it's taken a month or two to really find the right dose and everything, but then the kid is doing really well. Well, you may have to make some adjustments with time because kids are bigger, the heavier weight, they may require different dosing. Remember, when you go from childhood through puberty, liver function slows down a little bit, so the blood levels actually are going to be a little higher for that reason. So there are times where you have to adjust doses, but you get on a dose and somebody's doing okay, and then what you start seeing breakthrough symptoms, like maybe irritability or aggression or something like that. there's not compelling evidence that tolerance is developed. It's usually something else is going on here, okay? A new psychosocial stressor, or, you know, some of these kids have comorbid bipolar disorder, you know, and they're treated for ADHD, and at the age of 11, you start seeing bipolar stuff come up. So that's the current thinking about that. These are just alternate or medications that can be used for insomnia. This is absolutely experimental. There's 2 studies using high-dose melatonin, and I would not recommend that, since, number one, it's with kids, and you just really don't want to hurt kids, especially. But the other thing is there's only 2 studies. The company that makes Focalin, which is sort of a Ritalin clone, their data suggests it has a little bit less impact on suppressing appetite, but it's probably not significant enough. It's probably a marketing thing more than a real thing. You can get dysphoria with some stimulants. Now, this is something that's odd about this, is I mean, you can't have comorbid depression, okay? Obviously, that's something to be addressed separately. But some of these kids, their parents or their teachers will say they look depressed. And, but many times you ask the kid, you feeling depressed? No. Well, you feel sad? No. Probably what's happening here is that a lot of these kids, even though this disorder is problematic and cause all kinds of problems in their life, also a lot of these kids, when they're not taking the medication, are more animated. They've oftentimes been class clowns if they've got a sense of humor, you know. But that gets toned down, and so the contrast between what people are accustomed to. I mean, this kid drives me crazy, but also he's kind of funny, you know, and he's got a lot of aliveness, and it dampens that. And people say, gosh, is he depressed? So you've got to watch out for depression, but the point I'm making is the stimulant itself actually can cause this. Now, if they've got real depression, then you can treat that with psychotherapy, or you can add an antidepressant. Inhibition of growth, the Church of Scientology really jumped on this years ago, but they still are railing about this. Oh, it causes suppression of growth. Well, there are a couple of problems with this, okay? First off is that the original research looked at kids, ADHD kids, treated with stimulants versus normal kids, and sure enough, by the end of adolescence, as a group, okay, the kids that had ADHD and were treated with stimulants were half an inch shorter. Not exactly huge, but Church of Scientology would make it sound like, okay, do you want like a normal hyperactive kid, or do you want a calm dwarf? You know, I mean, they made a big deal about it. But a few years ago, they did a study where they looked at medicated ADHD kids at the end of adolescence, and they looked at ADHD kids that had never been medicated, and they also were half an inch shorter than normal kids. So, you know, is it the drug? Well, probably not, but maybe. Okay, let me tell you what the maybe part is. If somebody's being given really high doses, and most of the time that's not necessary, okay, but I'm talking about just huge doses, there can be enough of the drug in their system at nighttime that it interferes, especially with their ability to go into slow wave or deep sleep during that first episode of slow wave sleep at night. And it's during slow wave sleep that people release human growth hormone. And so the truth is there probably are some kids who are taking mega doses that actually it is interfering somewhat with their growth by inhibiting the release of growth hormone. But that's absolutely the exception rather than the rule. Okay, now you can probably tell the slides that I drew myself, okay? I'm very impressed with this, okay? Let me show you something. Here, what we're looking at is cognitive functioning, okay? This is poor cognitive functioning, and then it gets better, okay? And here we're doing increased dose. Now, if you want to look at behavioral control, this kid that shut up and quit bugging everybody, if you keep pushing the dose, you keep getting more and more positive response. And this kid, you know, now isn't bothering anybody. In fact, they may be looking like they're going to sleep, okay? And if you get too high a dose, the most common side effect is this kid gets sleepy. Again, it seems counterintuitive with the stimulant, right? But what happens is you reach a certain point in dosing, and you start to actually get cognitive impairment, okay? So the name of the game is we want these kids to be able to function, and yeah, it probably is going to be good for them to not have as much hyperactivity. But if the drugs, and this would be an inappropriate use of the drug, is just behavioral control. If they push the dose too much for behavioral control, they actually start paying a price in terms of the ability for cognitive function. Okay, does that make sense? Click here to restore writing. I don't want to restore it. Okay, we already talked about that. Okay, so anyway, here are alternative treatments. Clonidine, like I said before. Kids that are really not doing well on standard treatments, there are several places in the United States where they have specialty clinics, where they really specialize in severe psychiatric disorders in children. Find that some kids, if you give nortriptyline, a tricyclic antidepressant, you add that on to stimulants that can work. It's not used very often, but got to keep in mind, on rare occasions you get kids that don't respond. Now, it seems like SSRIs are good for everything, Not here, though. Actually, Prozac can, not just Prozac, any SSRI can make things worse. Remember we talked before about that you can get affect blunting with antidepressants that have serotonin? Okay, anybody remember what the mechanism of action is?
Must be dopamine.
It's shutting down dopamine in the frontal lobes. Wait a minute, we've already got a problem with not enough dopamine activity in the frontal lobes. So, some of these kids have depression. Some of these kids have severe anxiety disorders. If you have depression, probably the best drug to use is Wellbutrin. Why? Because it's an effective antidepressant, but what does Wellbutrin do? It increases dopamine. Right?
Question.
Okay. Yeah.
So, if a child takes a stimulant for ADHD and you say they don't respond, and you talk about some of these other things, does that mean that they would be stimulated, or just also not stimulated but not an improvement in the symptoms?
Okay, a couple things here. One is, let's assume that the diagnosis is correct, okay? It's almost never do they not respond, okay? I mean, I would say practically every single kid with ADHD will respond to a stimulant. But let's say that you've maxed the dose on that and they're getting improvement, but it's not enough, okay? That's when you think about adding stuff.
Oh, okay.
Okay, and adding, adding this, or Strattera is largely done so that you have something that's working in the evening time. Okay. Yes, ma'am.
Is the dosage for Wellbutrin in ADHD the same as it would be for treating depression?
Good question, and it's not well documented. It just isn't. So most people say, yeah, I use the same dose you would with depression, but I have seen no studies that look at that. So you'd start off, probably it's going to require at least 150 milligrams a day, but then, you have to adjust the dose. Yes?
I had a question about the Wellbutrin. Didn't you say that it can cause
That's okay.
anxiety symptoms in adults
can.
with depression? So is it the same in children?
Well, it can, but the thing is, here, these kids already are dopamine deficient. And so if you take somebody and, let's say they have depression and they have anxiety, and you give them Wellbutrin, it may throw gas on the fire and they get more anxiety symptoms. But these kids, the problem is that they are dopamine deficient, and so when you increase the dopamine, it's kind of bringing it maybe up to normal levels. Now, you're going to get some kids that will get jazzed on Wellbutrin, so it happens. This is Strattera. Strattera is FDA approved for treating ADHD in children and adults, but it's an antidepressant. And if you look on your quick reference sheet, it's listed under the category of antidepressants. And the company that makes this, same people that make Prozac, they did research and it proved to have antidepressant effects, but then there's just so many antidepressants out there on the market they thought we would probably make more money if we use it to treat ADHD, because they had some data that showed that it was effective with ADHD. So they decided to market it as an ADHD medicine, even though it is technically an antidepressant. Now, for that reason, it's got the black box warning that says it may increase suicidal thoughts and behaviors, just like all the other antidepressants. And here, the research is better in terms of dosing. And so the dosing that is effective, really for most kids and teenagers and adults, is a higher end dosing of 1.8 milligrams per kilogram. The effect size you can see here is not bad, but it's not nearly as robust as you get with stimulants. Okay, there's been 3 cases of liver problems, but this is in hundreds of thousands of people treated, so it's not enough to get people worried at FDA about this. Now, Strattera is a norepinephrine reuptake inhibitor, so you may be wondering, but wait a minute, this is a dopamine problem. How can we inhibit norepinephrine and get dopaminergic activity? I know all of you are just, perplexed and confused about that. Okay, so let me show you what the deal is. All right. Now, you got to keep in mind that dopamine and norepinephrine are kissing cousins. Okay, the molecular configuration is almost identical. They're both made from the amino acid tyrosine. Now, here's what happens then. You take Strattera, and it blocks reuptake of norepinephrine. Now, there's also lots of norepinephrine, well, everywhere in the brain, okay, the frontal lobes included. So you're building up large amounts of norepinephrine, okay? But what happens here is that this molecule, being so similar to dopamine, is actually not only being sucked back into and recycled by norepinephrine nerve cells, but it's sucked up by dopamine cells, and it is then reconfigured into dopamine and released. So the original impact is to block reuptake of norepinephrine, making more norepinephrine, but sort of the downstream effects is actually subsequently increases the release of dopamine. Okay? Is that confusing?
Yeah, I didn't get it.
Well, it may not even be important to know, but you want me to say it again? Okay. Okay, it's a norepinephrine reuptake inhibitor. Now, I should say, this is not just Strattera. We're going to see, probably in the next 2 years, some more norepinephrine reuptake inhibitors marketed as antidepressants. Okay? I mean, they're in the pipeline. Okay, so this is happening throughout the brain. And guess where else it's happening? Throughout the entire body, right? Okay. So it's blocking the reuptake of norepinephrine. Okay. Now, what this means is then you're going to have a buildup of norepinephrine in synapse. And also, remember, the neurotransmitter doesn't just stay there. It kind of spills over into, leaks into the fluid surrounding nerve cells. So its next door neighbor might be a dopamine neuron. And because chemically dopamine and norepinephrine are similar enough, it actually sucks up norepinephrine through the reuptake transporter on dopamine nerve cells, and then converts it into dopamine. And so in an indirect way, it actually eventually results in more dopamine availability in addition to norepinephrine. All right. Now, onset of action of antidepressants, extraordinarily broad. Sometimes within the first week you get some effectiveness, but sometimes you have to wait for weeks. Okay. What's the upside of this is that there's coverage for evening hours. Now, let me talk about one other thing that I think nowadays, at least among professionals, is not controversial, but continues to be something that people raise the question, and that is, should you only use stimulants during the week during school? And if you go to any reputable book on ADHD, okay, there's consensus across the board, you use it every single day. There aren't drug holidays. You don't take the kid off it in the summertime. And the reason is that the drugs don't harm kids, okay? They're very safe. But secondly, ADHD isn't just about making better grades in school. it's about being able to make friends. And you know what, when I don't work with people like this anymore, but when I was working, especially at Kaiser, what I would tell parents who are making a decision about using stimulants is I would say, you know what, I know we're really concerned about your son's grades, and that's obviously very important, but I'm going to tell you what the #1 reason is for thinking about using stimulants, and that is, let's get this kid through childhood and adolescence having some self-esteem. And the icing on the cake is doing better in school. Because if everybody rejects you, there's always conflict, you know, that really hits kids hard. Okay? If the drug were dangerous, if it had significant side effects, there might be a reason for taking them off, but that's not an issue.